இல்ல மேம், அவர் ஒரு எமர்ஜென்சினாரு மேம், நடுவுல ஜாயின் பண்ணிக்கிறேன்னு சொன்னார் மேம்.
சரி, okay. We will start.
Okay, ma'am. We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Urogynac, organized by TNFOG. So it's my privilege to introduce the convener of today's webinar, Dr. Gayatri N. Ma'am. Ma'am is the consultant at Shamla Nursing Home, Trichy, and executive member of Triox. I welcome you, ma'am.
Thank you. Thank you, Sahiti.
And I hand over the session to you, ma'am.
It is my great pride and privilege in being the convener along with Dr. Radhika Gauri for this TN Marathon CME, which is being conducted every month on the second Friday. Before going to the proper program, let's invoke the blessings of the Almighty and do a virtual lamp lighting. Sahiti.
நீனாரும் கடலுடுத்த நிலமடந்த செழிகொழுகும் சீனாரும் மகனமென திகழ்வடத கண்டமெனில் எத்தனவும் அதிசிறந்த திராவிடர்கள் திருநாடும் தக்க சிறு திரை முதலும் தனித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வழங்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
A very good evening to all the faculty and the delegates. I now call upon Dr. Sampath Kumari, the founder of this program, Marathon CME, very successfully conducted for quite a long time, making it true to its name, Marathon, to introduce the program and our chief guest. Over to you, madam.
Thank you, Dr. Gayatri. I welcome Dr. Shyamal Shetty, sir, and our president, Dr. Vidya Prabhakar. I think Alpesh sir will be joining soon, and I welcome all the faculties and delegates. This Marathon CME, we are conducting on every month, as Gayatri told, the second Friday. We have 3 sessions of this program. We select a single theme. This month the theme is Urogynac. The first session being the UA session. 2 UAs will be giving the talk, and it will be judged by the same judge throughout the year. The best UA orator will be given the awards as UA orator of TNFOG in the annual conference. The second session is the update. Today we have the update on urodynamics by Dr. Meera Raghavan. And third session being the case-based scenarios. So this is the TNFOG Marathon CME we are conducting for more than 3 years. Now I welcome our President Dr. Vidya Prabhakar to introduce our guest of honor, Dr. Shyamal Shetty. Welcome, sir. Dr. Vidya.
Good evening. Thank you very much.
Thank you, ma'am. Thank you, ma'am. Can you hear me?
Yes, sir. Yes, Vidya, madam.
Yeah. So, good evening, one and all. And it's my pleasure and privilege to be here at this Marathon CME. As everybody has said already, it's been, prolonging like a marathon, and it's still going strong, actually. So, so many months of this marathon CME, and all focused on one particular topic every month. And so today is Urogynac, and Madam has already said who are all coming for that. And it's my privilege to welcome Dr. Shyamal Seth, sir, who is the guest of honor today. He is the president-elect the Bengal Ops and Gynae Society, Vice President Foxy 2025, and he is also medico-legal advisor. He prefers to have a short and sweet CV. And with that, I welcome you, sir, and to say a few words.
Shyamal sir,
Thank you very
welcome.
much,
He has
madam.
been a wonderful conference in Calcutta and his Yuva is waiting in Shillong. Welcome, Dr. Shyamal sir.
So that conference was excellent because of the participation from all of you. You know, participation from the so many eminent faculties make a conference successful. Thank you very much, madam, for inviting me to be the guest of honor on this occasion. So marathon CME, I don't know how many CMEs are already have been taken place and how many are you going to do in next over the period of months. It's a nice concept. Urogynae is such a burning and so much of discussing topics these days. And almost in every conferences, we are having some topics or workshops on Urogynae. And this is a never-ending subject. Everybody has to learn something out of any CME, out of any webinar, out of any conference, any workshop. This is such an important topic, such an important subject theoretically as well as practically as far as operations are concerned. So I believe whoever participates, whoever are the faculties are going to contribute to all those who are going to listen to these events, and everybody will gain something out of this so that they can utilize or implement all these things in their own practices and give their patients the best services. Thank you very much, madam. I wish this program to be very, very successful as all of your events, all of your efforts as of now happen to be very, very successful. Regards, madam. Regards to all of you. Thank you very much to all participants, faculties, and listeners. Thank you very much.
Thank you, sir, for those really kind words. And you've been really appreciative, and you've encouraged us to do more as well. So, as you very rightly said, Urogynac is one burning problem which probably affects most of the women, and especially at around menopause. But it is, I think, probably a little underrated, or maybe the focus has not been there on that. So, I think it is all the more important that we have more CMEs like this to focus on these problems. And to learn more, as you very rightly said, I think all of us are going to learn something today. Some learning points are going to be there. And Dr. Meera Raghavan is there. Definitely, she's going to share, some of those, scintillating facts. Thank you very much, sir, for being with us.
Thank you very much.
Thank you,
very
sir.
much.
If time permits.
So I have to leave because I am attending already a meeting in our Bengal society.
Yes.
Uh-huh. Yeah,
Thank you
must be
so
busy.
much, sir.
Thank you,
Okay.
sir.
Thank you. Thank you. Thank you, madam.
As of now, we have 1 or 2 registration. Okay. Now, Vidya madam, shall we proceed with the scientific program?
With the
Yes,
US
madam.
சாகிதி அவரு அல்பேஷ் சார் எப்ப ஜாயின் பண்றாரோ அப்ப சொல்லு பார்த்தேன்.
Okay. Yes, ma'am. We'll keep an eye on it. Yeah.
Okay. Yes.
Yeah. This will go to our UA session, for which we all are already well versed with our 2 judges, Dr. Shanti and Dr. Kartika, who've been with us throughout this marathon CME, trying to judge all these UAs. Over to you too, madam. Please introduce the UAs and start the session, madam.
But the first session is on evaluation and management of SUI by Dr. Harini Shivamani. She is a consultant urogynecologist from SRM Global, and she has more than 6 years of OB-GYN experience, and she is also a reviewer and contributor for various journals, and she is a member of RCOG, and she also has achieved Distinguished Professional Award in National Statistical Day. Over to you, Dr. Harini.
Good evening, all. Am I audible?
Yeah, you're audible.
Sharing my presentation. Okay.
Yes, Harini, you can proceed.
Harini?
Good evening, everyone. So my topic is about stress urinary incontinence, the evaluation and the management. So a short definition from the Joint Committee. The urinary incontinence is defined as the unintentional, accidental loss of urine, wherein stress incontinence is the type of involuntary loss of urine that happens during physical movement or activity, which is any condition that elevates the abdominal pressure or that puts in a stress on the bladder, like cough, sneeze, laugh, standing up from a sitting position, running, and heavy lifting. Stress incontinence is certainly not related to psychological stress. So the risk factors are age. So age, there is a bimodal distribution. It is more prevalent in aged postmenopausal women due to atrophy and lack of estrogen. And it is also reported in young athletic women who are physically active and puts more pressure on the pelvic floor. Then obesity and adiposity. Parity and the mode of delivery is one of the most important risk factor. Pregnancy per se increases the chance of SUI by 1.8 folds. And the dietary factors like caffeine and high aerated drink consumption will add on to the risk of developing SUI. There are evidences that menopausal replacement therapy could also lead on to increased SUI. Hysterectomy, which is one of the major procedure that is performed all over the world, is both abdominal and vaginal hysterectomy has been shown to increase the risk of stress urinary incontinence. And smoking is also one of the risk factor. Heavy exercises like people who are athletes with more involvement into gymnastics and trampoline have higher chance of SUI. Comorbids like diabetes, recurrent urinary tract infection, ischemic heart disease, physical impairment, and depression can also add on to the risk of developing SUI. So when it comes to evaluation of SUI, so it requires a detailed history. The history would help us to categorize the type of urinary incontinence, which could be a genuine stress incontinence, or it could be a mixed stress incontinence with a predominant stress urinary or a predominant urge component. And we would also have to elicit the history from the patient to know the precipitating events that would lead on to the urinary leakage. And also a specific notion to know the confounding variables like aging, any prior pelvic surgeries, or any previous treatment that the patient has tried. And there are drugs that could also add on to the risk of developing SUI, like antipsychotics, anticholinergic, diuretics, alpha blockers, and any history of narrow angle glaucoma. And one of the most commonly missed history with children and younger women is history of sexual abuse, which can present with SUI, wherein there will be a levator muscle spasm. And otherwise, where in secondary SUI, which could be due to any pre-existing diseases like connective tissue disorders of jaw growth. So we need to ask for the history of joint hypermobility and dryness. And this is a specific entity called complicated incontinence, wherein the women had a prior urinary incontinence surgery, or there is a neurological condition for which she's on treatment or which is diagnosed. On evaluation, found to have an elevated post-void residue, which is more than 30% of the pre-void volume. Any bladder pain or hematuria, recurrent infections, any suspected or proven voiding problems, symptomatic pelvic prolapse or previous pelvic irradiations, any radical pelvic surgeries, and symptoms that are suggesting fistula. So in examination, the first thing is, since SUI is more common in the geriatric age group, the general mental status is the first thing that we need to know before starting to diagnose and explain the condition to the patient. So we need to assess the ability of the patient to understand the risk, benefit, the limitations, and also the recovery involved with the surgical intervention. And we need to exclude the possibility of dementia by a geriatrician. So basic BMI is very important, followed by cardiovascular and the respiratory status. And in examination per se, we have to look for the abdomen, look for ascites and any large fibroid, which can also manifest with SUI. So we need, and while examining the abdomen, we need to have a look on the scar, because if we are going to plan for an autologous sling, then harvesting the graft, we need to plan for it. And in vaginal examination, we need to look for atrophy, prolapse, or assess the pelvic floor muscles and also tone of the pelvic floor muscle and the anus. There should also be a brief neurourological examination to know the perineal sensation and the anal tone to know the neurological component. So this is how we do a bulbocavernous and the clitoral reflex to rule out parental neuropathy, and the modified Oxford scale that we use to measure the pelvic muscle strength. And in examination, and also in history, we need to evaluate the severity of the stress incontinence. But to know the level and the type of the pad use and how much is the pad getting soaked in a day's time. So to know the severity, we can count it for 24 hours home pad test or 1 hour office pad test. And what she uses for the stress urinary incontinence, like panty liner or a continence pad or an adult diaper, and how much it is bothering the daily living is another indicator of the severity of the urinary incontinence. Cup stress test, which can be performed both in supine and also in a standing position, with a standardized way of measuring the cup stress test with a bladder volume of more than 200 ml. We can use it also to know the objectivity of the improvement post intervention. So before and after the treatment, the cup stress test gives us the rate to which the symptom has been improved. And bladder diary will also give us an estimate of the patient's intake and the any dietary modifications that are included, any fluid restriction that has to be planned to modify the lifestyle changes. The bladder diary provides a better key. And the basic evaluatory test will be the urine test, both urine dipstick and culture sensitivity. If the patient has symptoms of UTI, then directly we need to give for the culture sensitivity. If it is an asymptomatic patient, we can do a urine dipstick test. And if the nitrites, leukocytes, or the pus cells are more, in that case, we can do a culture sensitivity. Post-void residual urine estimation is also important to rule out any additional voiding dysfunction or urinary retention in the patient with SUI before planning for any surgical intervention. It can be done either by an ultrasound scan and also by catheterizing after void. And also the symptom score and the quality of life questionnaires. There are multiple quality of life questionnaires which will give us a subjective score of the patient's suffering and also the improvement post-intervention. The special tests that are done for complicated SUI are the urodynamic testing, cystoscopy, and imaging like MRI to know the bladder neck and the urethral angles. So this is the bladder diary which can be given to the patient to know how is her daily intake of fluids and the daily bothering by the SUI. So coming to the management, starts with the non-surgical management, which are the lifestyle intervention like modify the dietary intake by cut-shorting the caffeine consumption, by stopping smoking, and also by weight reduction to bring down the BMI. And we should also make the fluid intake modification if they are consuming more liquids. The next intervention will be the first line intervention will be the physical therapy, that is the pelvic floor muscle training. So which is tried for at least 3 months before going for any other intervention. At least 8 contractions must be performed 3 times a day. And it is shown that 8 times the patients are likely to report cure when it is performed in a proper way. The pelvic floor muscle training will narrow the levator hiatus and also improve the muscle tone. So this will reduce the leakage by an average of 1 episode per day in a woman with SUI. And there is a drop in the leakage with the pad test. Other non-surgical tests like electrical stimulation and biofeedback helping with the pelvic floor muscle therapy can aid to the motivation and to the adherence, but studies have not reported any significant improvement with the addition of biofeedback to the pelvic floor muscle therapy. Behavioral therapy includes like bladder training for a 6-week time, which can be used as a first line for both stress and mixed urinary incontinence. Neurostimulation like transelectrical neurostimulations are all there, which are in the process of studies. The pharmacological agents that are used in the management, the first line will be the vaginal estrogen. So we can offer vaginal estrogen to postmenopausal women with SUI and also symptoms of genitourinary syndrome of menopause. So it is not certain regarding the duration of use of vaginal estrogen. So usually it is practiced that before and up to 1 year in the postoperative period, the use of vaginal estrogen is adding beneficial to the recovery. In women who are taking oral conjugated equine estrogen as HRT, if they are developing SUI or with a worsened SUI, then we need to stop it and discuss the alternative hormone replacement therapy. So the next drug of choice will be the duloxetine, which is a serotonin norepinephrine reuptake inhibitor. The dose is 80 milligram daily It can be combined with the pelvic floor muscle training. If it doesn't show any improvement after 3 months of dedicated pelvic floor muscle therapy, then we can add on with the drug. So it has shown a significant improvement, but at the cost of higher side effects like nausea, vomiting, dryness of mouth, constipation, dizziness, and insomnia, which will lead to the higher withdrawal rate of the drugs. And it is also that alpha agonists are also shown to have some improvement with the stress urinary incontinence. The adjunct to the therapies or the kind of components which are used for a coping strategy are the absorbent or the containment products, urinals, and toileting aids. And the other thing could be catheter. It could be intermittent, indwelling, or suprapubic if there is an SUI with urinary retention. There are intravaginal and intravesical devices which can be used to prevent leak. It has to be clearly stated that these therapies will only help to palliate the symptoms and it will not offer any cure. Next, coming to the surgery. So surgery is always a shared decision making. The benefits and the risk of the surgical treatment and the options have to be discussed with the patient and also the caretaker. The uncertainties regarding the adverse effect, the long-term success rate, and also the chances of recurrence, the length of the hospital stay, type of anesthesia, particularly if there are any comorbids for the patients, the surgical incisions and the recovery period and the complications associated have to be discussed in brief with the patient, and then we need to proceed with the surgery. So this is the classification by Bleivers and Olsen of 1988 to know the type of stress urinary incontinence based on the fluoroscopic image of the bladder. So in surgery, we divide it into two types of SUI, that is uncomplicated stress incontinence and the complicated. In uncomplicated, the surgical techniques that can be used are the traditional pubovaginal sling, which is the gold standard, and mid-urethral sling, which is retropubic TVT or TOT, which is also very commonly performed with an equal success rate, and colposuspension, which is being traditionally done by open Birch colposuspension and also by laparoscopic. In case of complicated stress incontinence, colposuspension or mid-urethral sling can be done, and also external compression devices, which are not that available here in our place, which include adjustable compression therapy and also artificial urinary sphincter, and there are also adjustable slings. In autologous pubovaginal sling, it was originally described for the intrinsic sphincter deficiency pathology of SUI. Here, the sling is placed beneath the proximal urethra and the bladder neck to support and also to compress to prevent the descent during a raised intra-abdominal pressure. The overall success rate is 82 to 84% in a 2 years period. So it has been evolved from using gracilis to pyramidalis to fascia lata and at last to the rectus fascia. While comparing the pubovaginal sling with the mid-urethral sling like TVT and TOT, the 2-year cure rate is significant, is almost same with pubovaginal sling and the TVT, but it is significantly low with TOT, that is 34%. So in comparison with other procedures, the pubovaginal sling is as effective as the mid-urethral sling. Colposuspension in patients with genuine stress
Dr.
urinary
Arni,
incontinence.
you have exceeded the time.
I'm just going to end, ma'am, just with the flow chart. So this is the picture of Birch colposuspension. And there are new advances like laser therapy, but there are no evidences unless it is done in a closely monitored research study. So this is the flow chart in general, concising the entire presentation. So first it starts with the clinical assessment of history and classify the type of incontinence. And then with the general assessment will include bladder diary questionnaire, assess the quality of life, perform the physical examination of abdominal, pelvic, and the neurological examination, do the cough test, urine analysis. If it is a stress incontinence, start with a lifestyle intervention, pelvic floor muscle train, bladder training, and in a stepwise, if not willing for surgical or not suitable to surgical, then we can go for medication. Otherwise, we can go for a surgical modification. Thank you.
Good presentation, Arini. You have elaborately discussed on the evaluation and management. For the sake of postgraduates, can you highlight on what is masked or occult SUI?
In case of women who have pelvic organ prolapse, there are chances that the SUI, which is already prevalent in that patient, can be masked because of the descent of the bladder. So once we correct the pelvic organ prolapse, the SUI will manifest. So this is commonly referred to as the occult SUI in case of women with pelvic organ prolapse.
Can you diagnose it?
We can diagnose by reducing the prolapse with the use of a pessary or a containment device, and then we can ask her to do the cuff stress test, with which we can be able to diagnose the SUI.
So what is the difference in the management of occult SUI and SUI with pelvic organ prolapse?
Sorry, ma'am, I could not hear.
See, a woman, the primary complaint is pelvic organ prolapse. There are two women. One is a woman with only symptom is pelvic organ prolapse. The other woman has SUI, frank SUI, along with pelvic organ prolapse. Is there any difference between these two? How would you manage these two women?
Ma'am, if there is
One
only
has
pelvic
occult
organ,
SUI, the other one has frank SUI with the she's symptomatic.
yes, ma'am. If the woman has pelvic organ prolapse without SUI, we have to evaluate for occult SUI by doing a cup stress test after reducing the prolapse. If the SUI is present with that, then we'll have to discuss with the patient that there are chances that it will manifest post surgery. So we can offer her for concomitant SUI sling procedure. If there is both pelvic organ prolapse and SUI, a frank SUI, then we need to evaluate for the cause of the SUI, and if it is either due to hypermobility or IST, we can offer for a concomitant surgical intervention along with the pelvic organ prolapse.
So you mean to say that both has to be concurrently managed and there is no difference, is it?
In this, we can directly offer them both, ma'am. In the other one, we can give them the choice to choose, opt for whichever they want.
So actually speaking, in occult SUI, we are supposed to do concomitant surgery. But when women has SUI as such, okay, the surgery should be in two sittings. One for pelvic organ prolapse, okay. The other one, another sitting, you're supposed to do the SUI surgery.
SUI correction.
Okay.
Okay. Ma'am.
Based on what you will decide whether you are going to do a sling or you are going to give some other urethral bulking agents.
Ma'am, based on the leak point pressure and the urethral closure pressure with the help of urodynamics, if it is an isolated genuine stress incontinence and there is that is due to hypermobility, in that case we can go for colposuspension.
So in the other case, if there is no hypermobility, the surgery will not help much.
Sorry, ma'am. Hello? Sorry, ma'am, I could not hear.
No. Only in case of hypermobility, sling surgery will be helpful. So if there is no hypermobility, then the urethral bulking agents may be of use.
No, ma'am. Sling surgery will be helpful for both intrinsic sphincter deficiency leading to SUI and also hypermobility or leading to SUI. Urethral bulking agents are usually used for IST SUI.
Actually, they are temporary methods, like the first
And
choice
it is
would be
used
always
as a second line. Yeah. Yes,
yeah.
ma'am.
First line is always sling surgery, right?
Surgical correction. Yes, ma'am.
So can you elaborate on the bladder diary? How many days you like?
Ideally, it has to be done for 3 days, but in practice, we are following for a 24 hours bladder diary. One day on a holiday and one day on a working day.
So you mentioned about bladder training. Do you give bladder training for all women with SUI or what?
No, ma'am. In a mixed urinary incontinence, we can try with the bladder training.
Because when in case of mixed urinary incontinence, we need to treat the predominant symptoms. So to know, assess that, okay, you give both. So first is always bladder training. Then if she's not, then SUI would be the predominant. If that is the predominant condition, maybe you have to treat that. Okay.
Yeah. Okay.
Okay. Otherwise, it was a good presentation, Dr. Harini. Thank you. So we'll move on to the next presenter, Dr. Swati. She's MBBS, MS, OBG, MRCOG, FMAS, FRM, and she's a consultant at Prashant Hospital, Chennai. And she has an experience of 8 years, and she has an expertise in basic and advanced laparoscopy, operative hysteroscopy, evaluation and treatment of infertility, and management of menopause and PCOD. So her areas of interest are minimally invasive surgery and reproductive medicine. Over to Dr. B. Swati to talk about the ureteric injuries and gynec surgery. Dr. Swati?
Dr. Swati?
Swati irukangla? Dr. Swati, where are you? சித்திரகலா முதல்ல லாகின் பண்ணிருந்தாளா?
மேம் பார்த்த மாதிரி ஞாபகம் இல்லை மேம். மேம் இங்க சுரேஷ்னு ஒருத்தவங்க இருக்காங்க.
இருக்கேன்.
மேம்.
டாக்டர் ஸ்வாதி? சாந்தி, நானு மீரா ராகவனுக்கு போன் பண்றேன். இருந்தா we will proceed with the talk. அவ்வளவு காணோம் ஸ்வாதிய. காயத்ரி, give a call to the ஸ்வாதி.
ஓகே மேம். ஓகே மேம்.
நான் அதுக்குள்ள காயத்ரி ஸ்வாதி எடுத்தாளா?
மேம் கேக்குதா மேம்?
காயத்ரி ஸ்வாதி எடுத்தாளா?
டாக்டர் ஸ்வாதி போன் எடுக்கல, பட் she is there.
She is there. I don't know what is happening. No, now you call upon
We will go to the second speaker, ma'am.
ஆமா, செகண்ட் ஸ்பீக்கர் தான் முடிச்சாச்சே.
Yes, ma'am. Then we'll go to Anjalakshi madam, ma'am.
அஞ்சலாட்சி மேடம் ஜாயின் பண்ணாங்களான்னு தெரியல. யூ இன்ட்ரோடியூஸ் டாக்டர் மீரா ராகவன்.
Okay, ma'am.
அவங்க
With this, we'll go to our main topic of the day.
Yes.
We are pleased to have Dr. Meera Raghavan, Senior Consultant Urogynecologist and Robotic Surgeon with us for today's program. She's a convener of TNFOG certificate course in urogynecology, and she's a proctor and trainer for the robotic platform. She has a board certificate lifestyle medicine physician. She is the National Board Specialist Committee member, treasurer SOVSI, TN chapter, core committee faculty member of the Urogynac committee FOXY since 2015. And she's also a scientific chair, AICC RCOG 2025. She's also the National Board Coordinator, Examiner, MRCOG Trainer, and Examiner. We are very pleased to have her with us, a winner of 32 gold medals in the undergraduate and a best outgoing PG student from PGI Chandigarh. We are pleased to have you with us, ma'am. Over to you. Adjoined in urogynecology.
Yes, joined ன்னு நினைக்கிறேன். நான் அவளுக்கு கால் பண்ணிருக்கேன். She will join at that. The Swati Suresh is here. I don't know what is happening to her.
Ma'am, I've joined, ma'am. I had
Ma'am, Swati ma'am joined.
Yes, Dr. Swati, then you can.
Sorry, ma'am.
Then we'll go back.
மீரா வெயிட் பண்ணட்டும். ஏன்னா அவங்க
முடிச்சிடலாம்.
ஆமா, முடிச்சிடலாம். Swati, you start presenting.
Yes, ma'am.
Shanti and Kartika is there, no? Kartika Prabhu.
Yes, madam. Yes, madam. Yes, madam.
Yes, let us start.
Ma'am, நான் அதுக்குள்ள இன்னொரு தடவை மீரா மேம் ஃபோன் பண்ணிக்கிறேன் மேம்.
சரி. Swati, you can start presenting.
Yes, ma'am. Yes, ma'am. At the outset, I would like to thank Sampat Kumari madam and Dr. Meera Raghavan madam for giving me an opportunity. Today, my topic for the day would be ureteric injuries and gynecological surgeries. I'll be quickly brushing through the incidents, the anatomy, what really happens and what we have to do to prevent it and manage accordingly. So as we all see, the incidence of ureteric injury, even though it's uncommon, it's quite a serious
Swati,
complication.
do you have PPT or not?
Yes, ma'am.
Have you?
Can you please share that, ma'am?
I've
There is a green color icon in the bottom.
Yes, ma'am. Yes, ma'am.
Yeah.
Is it visible, ma'am?
No, ma'am.
It started, ma'am. Yeah. Can you please, we can see the screen. Can you open the PPT?
Yes, ma'am.
Yes, ma'am.
Yes, yes.
Make it a full screen.
Yes, ma'am. Yes, one second. Is it visible, ma'am?
Yes,
please
ma'am.
go
Yeah,
ahead.
please.
So to continue, the incidence of ureteric injury, it is uncommon, but however, it's a serious complication. And the incidence varies anytime between 0.3 to 1%, and it varies according to the procedures. It's very important that when there's an ureteric injury to identify it early and treat it. Otherwise, we can lead to delayed diagnosis, can increase the morbidity, lead to fistula, sepsis, and kidney failure. What are the common risk factors? For our gynecological procedures, the commonest would be any endometriosis, large masses, any abscess, large fibroids, pelvic radiation, and sometimes even urinary tract abnormalities like duplicated ureter and pelvic kidneys. And intra-op, during the surgery, when we have a poor visualization due to a hemorrhage or when there's a extensive adhesiolysis we are doing in our radical cases as well, there are increased chances of ureter injury. So quickly brushing through the anatomy. The pelvic ureters, these are usually a retroperitoneal structures. They run from the renal pelvis and go to the bladder. And they're usually about 25 to 30 centimeters. They divide into the abdominal and pelvic parts, and we are more bothered about the pelvic part. The distal part is more vulnerable for injury during our procedures. Coming to the pelvic part, once within the pelvic cavity, the ureters, they start running down the lateral pelvic wall. At the level of the pelvic brim, they enter into the sacroiliac joints, they cross the pelvic brim, and at the level of the ischial spines, they turn anteromedially and pass lateral to the uterosacral ligaments beneath the uterine artery, commonly known as the water under the bridge, which is the commonest area for a ureter injury to happen. And also, the ureter lies in close relationship to the ovarian vessels, the uterosacral ligaments, and the IP ligaments. And at all these places, it's much more common for injuries to happen. And they also travel along the endopelvic fascia tunnel medially and anteriorly along the upper part of the vagina and enter into the bladder wall and then open into the trigone of the bladder. At this region, only in case of radical cases, the injury is more prone to happen. A diagrammatic representation of the same. Like I mentioned, the site of injury, the most common is at the level of the uterine artery, which is commonly known as the water under the shed, close to the cervix, and then is the IP ligament when we are doing an adenexectomy. Cutting the IP ligament at the level of the pelvic brim when it crosses the iliac vessels, lateral pelvic wall, which is just above the uterosacral ligaments and near the vaginal vault. What are the different types of mechanisms of injury? It can be of two types. One, either it can be a traumatic injury or it can be an ischemic injuries. And ischemic injuries being that they're most of the times the presentation is late and we are more worried in those cases. Traumatic being mechanical when there's any transection or ligation, crush injury, and thermal, which is being the most common because the use of energy sources, especially with the most of us into the laparoscopic surgeries, it's the most common way of ureter injuries. With the use of diathermy, harmonic, necrosis can happen, and this in turn causes damage. And what do we do? The approach to manage prevention would be the primary is the most ideal way. Pre-operative imaging is very important with either CT or MRI just to identify the high risk cases, even though not indicated in all the cases. In any cases of endometriosis or large cyst, it's very important that we do imaging and see. Planning of surgery is very important. Identifying cases of endometriosis, large cysts, and thinking about ureteral stents. Even though most of the surgeries don't require ureteral stents, when there is with endometriosis, there is involvement of the ureters, or when a large cyst, there's hydroureter nephrosis, it's important to plan for stenting. Intraoperative identification of bladder ureter, and most importantly, a meticulous surgical technique is important. Secondary prevention would be doing an intraop cystoscopy. In case when there's any suspected injury, it is always important to identify it then and there and repair to minimize damage. Placement of urethral stents wherever necessary, even though we have a doubt, even though a cystoscopy shows a normal jet of dye, it does not always mean that there is no injury, because only when there's a complete transition, it means that it couldn't it couldn't be identified on cystoscopy. Can mean only a complete transition can identify it. But however, at that point, if you have a doubt, always place a urethral stent and always call for help, involving a team and the urological team, and take decision. Intraop identification, recognition, and repair yields the best outcome. So evidence, what is the evidence of the cystoscopy and intraop identification? Cystoscopy increases the detection of the lower urinary tract injuries during hysterectomy. Even though guidelines do not recommend a routine cystoscopy, it can be a very important tool in identification. Sometimes cost effectiveness now supports universal use of cystoscopy. And also there are a lot of dyes which are available as well. ICG can be introduced retrograde into the ureter or used systematically with various techniques. With also a lot of emerging techniques, dyes can be very promising. It provides, and with robotic surgeries, it provides real-time visualization, especially in complex cases as well as endometriosis. So stepwise identification, what do we do? Steps before dividing structures, it's very important to identify the ureter part. When we are at the level of the IP ligaments, when we are not able to find out where the course of the ureter, it's always important we open up the leaves of the broad ligament, because at the posterior leaves of the broad ligament, the ureter is held. And even though you're not able to see the ureter, opening up the leaf will definitely push the ureter down, and you can safely take the IP ligaments. This is one of the commonest methods which is used by surgeons, so safely, so that we prevent an injury at the level of the IP ligament. And then when we are doing a uterine artery, always stay medial. Going more lateral, more cause of injury can happen. And proper use of thermal energy, excessive use can, again, especially at the level of vaginal wall, can lead to injuries, mainly post-op late development of late fistulas. Mobilize the peritoneum, perform limited ureterolysis. It's very important, young surgeons, when starting to practice laparoscopy, to know ureterolysis, to perform it so and when necessary. And use of stenting, cystoscopy selectively. Always reassure before closure. If there is any doubt, call for help and identify it then and there, and repair it. So intraop, adequate exposure of the pelvic organs is very important. Avoid any blind clamping and suturing to achieve hemostasis. And very important, like I said, care should be taken during diathermy. Meticulous care during dissection. Most of the times what happens is we don't, because of the bleeding, we are not able to identify what the structures are, and we get carried away. When you're doing a complex surgery, ask your assistant to always have a watch on the ureters, because we very easily tend to miss it and damage the ureters. Dissection, mobilization of ureters only when indicated. So intraop, how do you make a decision? So like we said, first go along with the cystoscopy. Even with a normal cystoscopy, just proceed, and you have a doubt, put a stent and come. Or if there is an injury happened intraop, you'll have to identify it. If it is a very small injury, stents can be put. But in larger injuries, it's important that either end-to-end anastomosis or a repair to the bladder using a Boris flap is done. End-to-end anastomosis, most of the time what happens is you need a good amount of ureter length, both proximally and distally. So in large, when it's transected fully, it's better we go ahead and do a Boris flap, the ureteroneostomy. So what are the outcomes? The stenting alone, in cases of small partial injuries, small urinomas or small leaks, can be suffice. But however, the size plays a very important role, and the type how we repair is important. Always tension-free, watertight repair has to be done, and ensure that you've put a stent and also continuous bladder drainage for a longer duration. Post-op imaging, when there is a post-op suspicion, always, when there is a problem, have a high suspicion post-op, keep a close watch on the patient, check the renal function test. In case of when the patient presents either with a delay, with a flank pain or loin pain, fever, any signs of suspicion, go ahead and do a CT urography, which identifies cases. And when that is not giving you any good answer, go ahead and do a retrograde pylography. Again, the management will depend upon the type of injury. If it's a larger one, we'll proceed with doing a repair rather than a stenting. So antibiotic strategy, standard perioperative prophylaxis, as per guidelines, are usually given. If the tract is entered or repair is performed, it's very important that we give them with a good cover of antibiotics, especially when we are putting a continuous drainage for the bladder. So it's important that you always call for help in complex surgeries, identify a repair, or when you feel that the repair is beyond scope to get to repair in your hands. Coordinate with also the infectious team to take care for sepsis or complex wound contamination. I will also like to put a word on the training. Very important that we just know how to use our energy sources, know a full thorough background of what the energy source is, how it has to be used, what the lateral spread is, so that we can use it accordingly. And should have a pre-operative, intra-op and post-op checklist to identify the high-risk cases, plan prior, and go ahead for the surgery. Intraoperatively, identify the ureters, keep them under watch, and always ensure that the ureters are looked at the end of the surgery. Audit for ureteric injury cases, rates, and also review that. So this is just a one-page checklist which I told how to use see pre-op, intra-op, and post-operatively. So my key take-home messages would be, even though uncommon, they have a major morbidity. It's important to identify and place stents wherever necessary. Intra-op, expose the ureter, avoid blind energy, use selective cystoscopy and stents wherever necessary. Post-op, have always a low threshold for CT urography, check the drain creatinine. The golden rule would be see it, spare it, and stent it wherever in doubt, rather than leaving it there and coming and looking at it post-operatively. Thank you.
Thank you.
Good presentation.
Yeah.
Thank you, ma'am.
So, how would you classify the ureteric injuries?
Ma'am, it can be classified as early and late post-op injuries, or traumatic and ischemic injuries is what is commonly classified into based on what is the type of injury.
So you have a classification like type 1, type 2, type 3. So based on that, you plan your thing. If it is type 1 injury, it means that it is just hematoma. So type 2, it is less than 50% of transection. Type 3 is more than 50% of
and complete transection.
Yeah. 4 and 5 would be like avulsion with devascular. The zone will be less than 2 or more than 2 centimeters.
Yes.
Okay. Only for type 1 and type 2, you can go ahead with stenting. That would suffice. The other things you have to, and you would have classified the what to say, treatment based on the exact site where it has occurred. Right?
Okay.
So upper 1/3, mid 1/3, and lower 1/3. Right. So
yes.
That's how we usually.
Okay.
And the common site, I mean, one more common site where the ureteric injury occurs is at the level of pelvic brim, where it crosses, right?
Ovarian vessels.
So no, crossing of commonly occurs.
Commonly occurs.
So, what procedure could cause ureteric injury at that site?
Ma'am, lymphadenopathies when we are doing a pelvic lymphadenopathy or radical hysterectomy.
Okay. Any other obstetric procedure during emergencies?
Obstetric hysterectomy, ma'am.
Obstetric hysterectomy, it is near the uterine artery. Clamping. So other procedures.
Internal artery ligation.
Yeah. So that is
internal, yes.
That we need to remember.
Keep it.
Okay. Fine.
For stenting, if you are doing for a difficult case of endometriosis, what is the role there for prevention or identification of injuries?
Ma'am, most commonly, most of the surgeons now, they don't use stent. In case of endometriosis, when we are using a stent, it will be mostly for the prevention, ma'am.
No,
So
the
that is for
concept
actually it's for early identification.
Identification and prevention.
Identification.
They
So
say
that
that
intraoperatively
prevention
to
is-
diagnose,
yeah.
treatment is better than diagnosing it post-operatively.
Yes, ma'am.
Good presentation, Shwati.
Thank you.
Good. Thank you.
Thank you, Dr. Shanti and Dr. Kartika for the constant support.
Thank you, ma'am. Thank you so
Thank
much
you,
for the
ma'am.
opportunity, ma'am.
Thank you, madam. Thank you for the opportunity, madam.
Yeah, sure. Thank you. Thank you. Anyway, I think Gayatri is not there. We will go with Anjalakshmi, madam. Are you there?
Ma'am, Anjalakshmi madam is traveling, ma'am. She'll join us shortly. She asked us to start the session, ma'am.
Yes, we will introduce Meera Raghavan then.
Yes, ma'am.
Meera Raghavan already we have told 32 gold medals in undergraduate curriculum. So everything already told. Vallavale, Nallavale, Meera Raghavan.
Ma'am,
Gayatri.
urogynecology அப்படின்னா மீரா ராகவன் மேடமோட பேர் அங்க இருக்கும் மேம்.
Yes, now Meera Raghavan will talk about the urodynamics.
Marathon dragging சொல்லவே இல்லையா மேடம் நீங்க?
Yes, Meera.
Thank you, madam. Thanks for the opportunity one more time. Thank you so much, ma'am.
Meera, any function?
My wedding anniversary, ma'am.
Oh, congrats. Many more happy returns of the day for
Thank
Mr. and Mrs. Raghavan.
Thank you, ma'am. Thank you.
இன்னைக்கு கூட உங்களை புடிச்சிட்டோமா?
இல்ல இல்ல அதனால என்ன மேம், சுவாதி கூட தான் பர்த்டே. மெனி மோர் ஹாப்பி ரிட்டர்ன்ஸ்.
ஓ ஹாப்பி பர்த்டே. அதனால தான் சுவாதி லேட்டா வந்தியா?
Thank you, ma'am. இல்ல இல்ல.
ஹாப்பி பர்த்டே விஷஸ்.
Thank you, ma'am. Thank you.
இது பார்க்க முடியுதா மேடம்?
நீங்க ஃபுல் ஸ்கிரீன் போயிடு மீரா, தெரியும்.
இப்போ?
Yes.
Yeah. So the topic given to me is gynecologist insight into urodynamics. We all know what urodynamics is, but we need to know, and from this presentation, I'm hoping to really clarify how to do a urodynamics, when it is needed, what will you learn from a urodynamics, and what kind of report do you expect as a general gynecologist from a urodynamics, which will help in the clinical decision making for a particular patient. So the three important rules for a urodynamics is, first of all, we need to decide on what question to be answered before starting a study, and we perform the study to answer this question. So if I want to know whether patient has got stress urinary incontinence or not, it's a clinical finding. But at the same time, I need to find out whether I'm able to demonstrate it in urodynamics, whether the patient has got overactive bladder, and whether patient has got any difficulty in emptying the bladder. Without answering these questions, I will not be able to proceed with the clinical management. So first of all, I need to be clear on what questions to be asked, and I will design the study according to the questions, and that will be customized. So have a clear indication for and appropriately select the test measurements and procedures. So not every patient will need a urethral profilometry and all that. You basically do a filling cystometry and a voiding cystometry. It's basically pressure volume analysis. That's all. And ensure precise management, proper quality control, and good documentation. And analyzing and critically reporting the results, which should also use a clinical interpretation with the clinical context, not like correlate clinically or just telling, I have seen detrusor overactivity. It will not make any sense to the general gynecologist. So these are very important aspects of a good urodynamic element practice. So why UD? To diagnose the underlying cause of a lower urinary tract dysfunction, to characterize the lower urinary tract dysfunction as to whether it is a storage symptom or a voiding symptom. anything which is related to urgency, frequency, incontinence is a storage problem. Anything related to difficulty in emptying the bladder, hesitancy, obstruction, poor stream is all voiding problem. And to formulate treatment strategies to improve therapeutic outcomes and to educate patients regarding their condition. So the main aim is to reproduce whatever symptoms the patient is telling. We have to importantly notice here that urodynamics has only 60 to 70% correlation with the patient's symptom. Very, very difficult in elderly patients because they will say continuously I'm leaking. What they might be having is a small bladder which is not able to hold, and it's also unstable in the sense it's overactive. Then they will complain of continuous leakage. So reproduce the troublesome symptoms, answer any specific clinical question, establish a clear diagnosis, also to help us understand the severity of the condition. How soon am I going to intervene? How soon am I going to put a tape? These kind of questions, and plan further investigations or invasive therapy. So when all should you do, when all it is not needed? This is what we are going to see. So it is not necessary when I'm going to put a patient on conservative management. Say if a patient comes with prolapse and SUI, and the treatment is pelvic floor exercises and some management and lifestyle measure, I should not ask for a urodynamics, because patient will do these conservative management and then we are going to evaluate. I'm not going to do an invasive therapy. In patients with uncomplicated SUI, again, very rare to see an isolated uncomplicated SUI. So this subset will be minimal. In patients with neurogenic bladder, at low risk of upper tract involvement, they will present only with urgency. So you don't jump in to do these kind of invasive procedures. It is definitely useful when I'm not able to correlate exactly what the patient is telling and my clinical findings. Patient is telling I have leakage when cough and sneezing, but when I'm asking her to do a Valsalva or a cough, she's not having any leakage. Then it is useful to determine whether it is stress-induced detrusor activity which she's complaining as incontinence. Or I have done previous treatment, I am not getting any result, patient is continuing to have the symptoms, then what next? That decision can be enabled by doing a urodynamics. I will definitely recommend and definitely do a urodynamics in patients with incontinence and pelvic organ prolapse when I am contemplating surgery for prolapse. So many people think when the patient has incontinence and more than a third degree prolapse, just correcting the prolapse will cure the incontinence. It is wrong. Any other important message I want to convey is a cystocele repair is not a corrective treatment for stress urinary incontinence. In fact, correction of the prolapse will actually worsen or unmask a stress urinary incontinence which has been masked by the kinking of the urethra due to a lowered bladder, which is the reservoir. So we're putting back the bladder in position where the incontinence can worsen or the unmasking of incontinence can be there. So mandatorily, this is recommended in a patient where we are contemplating a prolapse correction surgery if the patient has incontinence. First, to determine whether correction of the prolapse is correcting the incontinence or worsening the incontinence, whether we are unmasking an occult stress urinary incontinence, whether there is detrusor overactivity, so we can manage the patient appropriately. In patients with neurogenic bladder who require long-term urological management to establish a baseline bladder activity, most of these bladders are contracted, are small capacity and high pressure bladders. Bladder is like a balloon which should be expanding without any pressure buildup. If it does so, it causes reflux of urine, pressure building up in the ureters as well as in the kidneys, causing pressure-related backflow changes and potentially kidney damage and renal failure. So in neurogenic bladder, the aim of urodynamics, which is more frequently done than the rest of the patients to mainly determine the impact on the upper tracts and to evaluate for any renal damage. So uroflowmetry is one component of the urodynamics. It's the simplest and most useful. It's like an ECG which a cardiologist does, non-invasive and inexpensive. Basically, remember the rule of 20 in females. Females void 20 ml per second speed, and the whole micturition act is done by 20 seconds, and we void at least 200 ml should be there to give a proper interpretation of the uroflow. Our bladder capacity is usually about 400 to 500, and we get the first sensation to go to the washroom by about 150. So if we keep responding to the first sensation itself, our bladder will think that it's its capacity and start holding only 150 and keep signaling the brain to go to the washroom. So practice holding onto the bladder just for about 3 hours, whereby the bladder capacity becomes 400 to 450. Do not hold beyond 3-4 hours because that over distance the bladder and causes some kind of flaccid bladder, and these patients can potentially come back with recurrent UTI. So uroflow tells pretty much everything for us. And one step ahead of the uroflow in a clinical thing is the bladder diary, which will tell pretty much how much the patient is drinking, what type of fluids the patient is drinking, how much is the patient voiding every time. Is it a small bladder capacity not able to hold? Are they voiding too much in the nighttime? How frequently they are going? And is there any leakage at the same time? So a paper urodynamics is simply nothing but a bladder diary, and all patients should have at least a 3-day bladder diary before we go into a urodynamics when necessary. So this is how a bell-shaped curve of the normal flow pattern of a uroflow looks like. So the maximum peak is at Qmax, which I mentioned. For a female, anything above 12, but ideally 20 would be great. This is a plateaued curve where there is a prolonged flow, and it's suggestive of some obstruction at the pathway. So the pathway is basically urethral obstruction. In elderly patients, it's invariably due to distal meatal stenosis. There is nothing called distal urethral syndrome, urethral obstruction, bladder outlet obstruction. These are all fancy terminologies. This shows an outflow obstruction. In elderly patient could be due to distal meatal stenosis, due to aging and vaginal dryness. In younger patients, it is not due to urethral obstruction. It's invariably due to a tight pelvic floor, not allowing the pelvic floor to relax and giving resistance. When I explain to the patient, I'm trying to push the door from here, somebody is holding tight from the opposite side. So I will not be able to open the door. Same thing happens with the pelvic floor being tight. So younger patients, do not subject them to urethral dilatation. It is not the cause for outflow obstruction. And this is how the pattern will look like. This is a constrictive pattern. This, what I mentioned, was a lady with recurrent UTI and pale genital mucosa, poor flow and no response to alpha blockers. This is a box-shaped curve. This is suggestive of urethral stricture. This invariably happens to patients who have had repeated catheterization, repeated dilatation, which goes blindly. That itself damages the urethra, scar tissue forms, and patients develop urethral stricture. The final answer for this patient to improve the flow pattern will be a buccal mucosal urethroplasty and not dilatation. Dilatation will give temporary relief, but patient will further form scars and further obstruction of the urethra will happen, leading on to worsening of the outflow obstruction. This is typically a spinal cord injury patient who has got difficulty voiding and altered bowel function, recurrent UTI, and as I mentioned earlier, it's an unsafe bladder causing bilateral HUN. This is showing intermittent flow or a staccato flow and bursts of involuntary external sphincter contraction during voiding. During voiding, bladder contracts, sphincter relaxes. This is how it should be. But in the neurogenic bladder, the sphincter also tends to contract, what we call detrusor sphincter dyssynergia. When this detrusor contracting, sphincter should relax. But if it doesn't happen, that causes a staccato flow or intermittent bursts of involuntary sphincter activity. This is intermittent flow, and the patient is voiding because of abdominal straining. This stop-start measure is feature of, again, sphincter dyssynergia, and patient is using the abdominal muscle because there's no basic flow in the urethra. This is a super voider or a fast bladder. Patient basically leaks even before they reach the washroom. This is suggestive of an overactive bladder. See the Qmax, it is hit almost 50. So this is a super voider bladder. So multi-channel urodynamics is performed by using different catheters. One to measure the bladder pressure, which you can see the bladder is blue in color, and also placing it either in the vagina or in the rectum. You can see on the buttocks, there are 2 electrodes which are placed, which is showing the EMG, and we measure the flow. So let me go through how we do it. This is how the urodynamic setup is done. Patient is made to sit on a lithotomy couch-like posture, like a colposcopy couch, and we insert these catheters, and this is the computer which tells us the measurements.
Veera, 1 minute, Veera.
Yes, ma'am.
Chitra, unmute பண்ணிடுமா எல்லாரையும், நடுப்புற disturbance வந்துட்டே இருக்கு பாரு. சித்ரகலா.
Okay, ma'am. Okay, ma'am.
Okay. Veera, continue, Mary.
We can also incorporate a C-arm X-ray unit if we want to do video urodynamics, but video urodynamics is not required for everyone. It is for complex patients, especially pediatric patients and neurogenic bladders, where we are going to see different elements of the bladder and the urethral descent, depending on which we can alter the treatment. So basically, we fill the bladder, look at pressure changes. We ask the patient to void, look at pressure changes. In between, we will see if there is leaking. This is the simple way which we can do urodynamics. So if you look at the top, the P-apt is measured as the abdominal pressure, which is from a rectal catheter. I do not use vaginal catheter because it can slip off. The second one, which says P-ves, is the vesical pressure. The P-det is not measured. It is derived by the computer as subtracting the abdominal pressure from the vesical pressure. The EMG, which is the squiggly line in red, measures the sphincter activity from the surface electrode. Most of the time, to about 60 to 80% of the time, it will pick up correctly. So when the bladder is filling, the squiggly line should be very dense and peaked up. When the bladder is voiding, this should be completely quiet. If it is not quiet, that is suggestive of pelvic floor dysfunction or pelvic floor spasm. Detrusor function, normal detrusor activity, what I told you, during the phase, there should be zero pressure rise in the bladder. It should be relaxed. It should not be agitated. It should not be overactive. So no change in detrusor pressure. When we see any such pressure, that is detrusor overactivity. So as you can see, P-apt is red in color. It is the rectal line. R for rectum, R for red. P-ves is the bladder line. B for bladder, B for blue. Detrusor pressure is a subtracted pressure. So it will correspond to whatever P-ves is doing. So as you can see, I told you the detrusor pressure should not be rising at all. As you can see, there is a hump in the green line and there is leakage which is marked. So what is this showing? This is showing a detrusor overactivity. The detrusor overactivity can be either occurring in between the filling phase or at the end of the filling phase and neurogenic in nature as well. So volume, you have to notice at how much amplitude this is rising, how long it is going on, and how much of leakage has been happening, and associated with what volume, whether it is happening at a very low volume of filling or towards the end of the filling. These are the things which we notice. Look at this. 61-year-old lady, urgency and urge incontinence. So basically, patient has got urge incontinence. What we are looking for is their corresponding detrusor overactivity. So PABT is red for rectal. So PWES blue for bladder, and the green is corresponding to the rise in the blue line pressure. So the green line should be straight, but it is peaking so much twice. So what is this? Definitely neurogenic detrusor activity happening often, and this patient showing very significant contraction. Contraction activity with increasing frequent and higher amplitude contraction occur as the bladder continues to be filled, and this is one which is showing a terminal detrusor overactivity. Basically, patient gets bladder filled up without warning, they will have a detrusor contraction, there'll be a big leakage. Detrusor overactivity causing urge incontinence is a more troublesome form of incontinence compared to cough-induced stress incontinence, because cough does not happen all the time, whereas urge incontinence can happen all the time and patient can be really having bothersome incontinence. So it is important to identify. Cough also causes detrusor overactivity, and that is how we differentiate between pure stress urinary incontinence and detrusor overactivity. As I said, if there is cough, there should be no rise in the green line, but if there is leakage still, that is stress urinary incontinence. But when the patient is coughing, there is a rise in the detrusor pressure, that is the green line, and then there is leak, that is cough-induced detrusor overactivity. Why am I clarifying this? If there is no rise in detrusor pressure and patient is leaking, then putting a midurethral tape or continence procedure is the right way forward. But if the patient has detrusor activity when there is cough and there is leakage, this is definitely not stress urinary incontinence. This is cough-induced detrusor overactivity, and we should not be putting tape for this patient. We should be treating their detrusor activity, which is medical management. So that is why this differentiation is important. We also talk about Valsalva pressure, and we need to look at what maximal abdominal pressure that this leakage is happening. So higher the abdominal pressure and leak, better prognosis. If a patient is leaking less than 60 itself, this patient most likely has got intrinsic sphincter deficiency and not just urethral hypermobility, and has a poor prognosis for continence surgery and should be done only by experts, preferably a midurethral sling with a pubovaginal sling, not the TOT tapes. This is very, very important for us to identify. So urodynamics, as we have seen, not only finds what type of incontinence, helps us identify and clearly differentiate between detrusor as well as stress incontinence and the severity of the stress incontinence to determine what type of procedure will benefit the patient maximum. So this is a para 4, all normal delivery, having incontinence. There is leakage when there is cough, but there is no rise in detrusor pressure. This is a classical case of urodynamic stress incontinence. There is no detrusor overactivity seen in the PDET line, but patient is leaking. She will benefit by midurethral sling or a stress incontinence procedure. 50-year-old lady with a traumatic brain injury, recurrent UTI, self-catheterization. See the flow, intermittent with a hump every now and then. What is this suggesting? It is contraction of reduced strength and duration, failure to achieve emptying bladder with a normal time span. This is a feature of detrusor underactivity. The commonest cause for detrusor underactivity or a hypocontractile bladder or detrusor failure is diabetes in our population. Diabetes, by causing what we call diabetic cystopathy, affects the nerve endings in the bladder and causes detrusor failure or an acontractile bladder. For them, the treatment is clean, intermittent self-catheterization, not any other medication. It will not help them. So we need to identify why somebody has retention of urine. If you go and dilate the urethra, this patient only will have flare-up of infection because the motor is at defect, not the outlet. So it is very important for us to clearly categorize why patient has got increased post-voidal residue. Is it because of a motor pump failure, or is it because of an outlet blockage? So that will answer what next. So that is why we take these parameters like bladder contractility index for the benefit of a general gynecologist. If it's more than 150, it is very strong. If it's less than 100, you're dealing with the acontractile bladder. And this is what we need to look at. I'm now coming to the EMG. As I mentioned, look at the red line. The red line is showing multiple activity where the pelvic floor is tightened up. But during voiding, it should be completely relaxed. If the reverse happens, that shows a pelvic floor dysfunction or a pelvic floor spasm. This is about a bladder outlet obstruction. See the P-West, which is rising during voiding, and the P-det is also rising during voiding. Look at the flow pattern. It is plateaued. It is a box-like pattern, which is showing a Qmax of less than 10. Remember, I said in females, it should be more than 20. It is not happening. This is an outlet obstruction. If there is detrusor overactivity secondary to it, patient will have repeated increase in detrusor pressure. The flow will be very poor. This is a secondary detrusor overactivity which is developed over years. This is again a very quick number reference for general gynecologists. If it is more than 40, the BOO index, which the computer itself will give you, it is an obstructed flow. If it's less than 20, it is a non-obstructed outlet. So remember the magic numbers of 100 and 150 for the contractility, 20 and 40 for obstruction of the outlet. So contractility is a motor function of the bladder. Obstruction is that of the outlet, which is the urethra. So 100 and 150 for the bladder, 20 and 40 for the urethra. Very simple magic numbers for a general gynecologist who is not doing these regularly for you to understand. Dysfunctional voiding, which I told you, look at this flow. It's not a smooth bell-shaped curve. It is intermittent. That is because the pelvic floor is contracting intermittently. This is showing pelvic floor spasm or pelvic floor dysfunction can happen in even neurologically normal patients with previous history of abuse, patients with previous history of trauma, patients with previous bladder pain syndrome. They can, or even endometriosis for some time, can present with dysfunctional voiding. This is typical detrusor sphincter dyssynergia. As you can see, whenever sphincter opens, there is leakage, there is flow. If there is closed, there is no flow. This is corresponding to this. So sphincter should be relaxed when patient is voiding, but it does not happen, therefore causing intermittent flow. So before concluding, read all the pressure flow measurements in a proper holistic manner. No individual measure should be interpreted separately. Always interpret UDE, always with the clinical context, and repeat UDE whenever necessary, especially if you've not done them yourself. There is no way a cardiologist can interpret a treadmill without having been there. So it is important for us also to be there physically rather than interpret some trace which has been done by somebody. So what do I look when I interpret a report? I look at the uroflow. I look at the maximum pressure and the voided volume. I also look for the post-void residual volume. I look at the bladder pressure while filling. There should not be much increase in the pressure at all. And any abnormal rises in the detrusor pressure, which will tell me whether the bladder is compliant and whether the bladder is overactive. Whether there is any leakage, that will tell me whether there is incontinence. Whether the bladder is compliant, which means the bladder is relaxed. Voiding phase also increasing pressure. If the voiding phase pressure is increasing, that's a good bladder with good contractility. If there is no increasing in pressure in the voiding phase, that is the acontractile bladder. And flow during voiding, whether it is a proper normal flow or is it a constrictive or a restrictive pattern. And the EMG will tell me the pelvic floor activity both during filling as well as voiding. So on the final analysis, I need to report on 5 things. 3 belong to the storage, two belong to the voiding. Bladder is storage, urethra is voiding. So bladder, is it stable or not? If there is no rise in detrusor pressure, bladder is a stable bladder. If the bladder is compliant or not, the vesicle and the detrusor pressure should not increase too much on filling. It should be quiet. Then it is a compliant bladder, which means there will be no back pressure on the kidneys. Is the bladder contracting or not? That will be seen in the voiding cystometry. If there is no rise in pressure, that is a acontractile bladder. That completes my storage function. Now, coming to the urethra, I need to establish whether the urethra is competent or not. If there is leakage, the urethra is incompetent, which means there is incontinence due to urethral incompetence. That needs to be corrected. Is the urethra allowing flow to happen? If there is bladder outlet obstruction, the urethra is obstructed. Then we'll have to intervene accordingly. So this is how the final analysis of the urodynamic report will look like. 3 for the bladder, 2 points for the urethra, and that completes my clinical interpretation of the urodynamics. So it is actually not as difficult as we think. So recommend UDE whenever necessary, whenever appropriate, whenever it is going to make a difference for the clinical management of the patient, like any other investigation. Thank you very much for this opportunity.
Good evening, Dr. Anjalakshi here. Meera,
Good evening, madam. Good evening, madam.
Meera, that was an excellent deliberation. Very crystal clearly you have told for the gynecologist to understand the uroflowmetry and the urodynamics. Very nice. Thank you.
Madam.
Thank you.
Thank you. Thank you.
Fantastic, Meera.
Thank you, madam. Thank you, madam.
Gayatri, can we go with the next session? Dr. Meena, are you there?
Yes, madam. Good evening, madam. I'm there,
Gayatri,
madam. Good evening,
we'll go there.
Anjalakshi, madam, Sampath, madam.
Yes, ma'am. Good evening.
Thank
Happy
you.
wedding anniversary, Meera, madam. Happy birthday, Swati.
Happy birthday, va.
Swati ki solrava.
Swati.
Swati ki solrava.
Atika, illa Meera kara என்னவோ நினைச்சிட்டேன்.
இல்ல Meera, madam, happy wedding anniversary, madam.
Thank you, Meena. Thank you.
Gayatri, third session ஆரம்பிச்சிடு.
Yes, ma'am. With this, we'll go on to our panel. We have Dr. Meena Mahalingam with us. Special training. She's had a special training in urogynecology and microsurgery endoscopy. Basic newborn care and resuscitation program under IAPK. She's been the instructor with clinical experience of more than 23 years in tertiary care teaching institute. She's also a master trainer in M1 faculty and organizing member in national and international conferences.
We can go on with the panelist.
We have with us Dr. Chandra Ponisamy. She is a FOXY member since 1982 and a life member of a lot of associations, IAGE, ISAR, IMA, PCOI Society. She's the founder president of Namakkal Women Doctors Association.
Thank you, Dr. Gayatri. Yeah, you can proceed.
Next panelist, please. Dr. Radha Madhavi, the founder president of Tiruvannamalai OG Society. All these names are not new to us at all. When I say the name, almost none of them require actually a formal introduction, but it's my pleasure. She is a member of the ISAR, IMS, MBBS from Bangalore, MD from Adforce, DNB, and a PG diploma in ultrasound, presented many papers in the ASCOG and
Ma'am,
yes, ma'am.
Okay, ma'am.
Welcome, ma'am. Dr.
Thank you, ma'am.
Uma Brinda, who's an assistant professor in the Department of OBG, Tanjavur Medical College, and now the secretary of the Tanjavur OG Society.
Good evening, madam.
Vidya, who's a consultant OGGN and a lab surgeon in Sarvesh Medical Center and Max Specialty Clinic, Salem.
Thank you, ma'am. Thank you.
Thank you. And we have Dr. Sumangali, who's the associate professor of PSG Institute of Medical Science and Research, Coimbatore.
Good evening, ma'am.
Over to our Meena, madam, please.
Thank you, TNFOG, for the wonderful opportunity. And I would be presenting my slides. Let me share my presentation. Can I share the slides?
Yes, ma'am.
Yeah. Chitrakala, otherwise, if I'm not, I'll just try. Otherwise, you have to share.
Sure,
screen.
sure, ma'am. Sure.
I'll just try 1 minute.
மீனா நீ அனுப்பிச்சிடு, சித்திரகலாக்கு அனுப்பிச்சிடு.
மேடம் அனுப்பிட்டேன் மேடம். 1 minute.
என்ன மணி 6 ஆயிடுச்சு.
Yeah. Chitrakala, can you share the
Chitrakala?
Yes, ma'am. 1 minute, ma'am. Yes, ma'am. Slides are shared, ma'am.
Thank you, Chitrakala. So I have all the eminent panelists. So we would be dealing with the case-based management of prolapse and concurrent incontinence. As already the previous speakers have touched upon stress urinary incontinence, ureteric injuries as well, urodynamics, it makes my job very easy to take through the case-based management of prolapse and concurrent incontinence. Next slide. I have eminent panelists like Chandra Ponnusamy Madam, Radha Madhavi Madam, Uma Brinda, Divya and Sumangali Madam. So we have 2 cases. We would take you through the first case, wherein next Chitra. She's a 56-year-old, para 4, live 4, multiparous woman. All were full-term normal vaginal deliveries. Happened at home. She presents with the vaginal bulge. We can see from the picture. She also explains episodes when she could not pass urine when she goes to the toilet. On examination, we can see there is a pelvic organ prolapse, stage 3 uterovaginal prolapse with cystocele. And on doing a cough stress test, it looks positive. So what could be the diagnosis in this particular case? Chandra Ponnusamy ma'am.
Yes, good evening and thank you for the opportunity. What we commonly see, this is a case of prolapsed uterus along with cystocele, and it appears to be 3rd degree, and the cystocele bulge is also visible here. And she is 56 years already attained menopause. So it's a case of diagnosis is prolapsed uterus, 3rd degree.
Yes, ma'am. Also, she has complaints of leak. She tells on coughing. There is a leak as well. Yes, madam. On reducing the mass with a comfortably full bladder, we were able to demonstrate a leak. So
yes, we have to reduce the mass and we have to hold the urethral thing, and we'll ask her to cough.
Yes. So next slide. So this, as madam has told, in our common practice, we see a uterovaginal prolapse, and on reducing with a comfortably full bladder, if she has a leak, we do say there is a stress urinary incontinence. So next slide. How does uterine prolapse cause SUI? Madam, can Radha ma'am explain why there is a prolapse in SUI, madam?
Yes, when uterus comes prolapsing, it takes the uterus angle, that's the urethral cystocele, bladder urethral angle also gets pulled up, and that angle is lost. so that the urethral function will be dysfunctional and it couldn't able to contract the urine. So because of the descent of this angle, bladder urethral angle gets pulled down.
Yes. Yes, madam. So, as we all know, when there is a prolapse, it pulls along the bladder down. The urethra is at a higher position. The uretrovesical angle is normally maintained, but here this vesical angle is not maintained. The urethra is at a higher position and the bladder it is at lower position. In that case, the patient is not able to void. So, uterine prolapse can cause SUI because there is a weakening of the pelvic floor diaphragm. Next slide, please. As madam has
Usually,
explained,
I'll add something where usually patients will say that when I use my finger and reduce the thing only, I'm able to pass urine.
yes. So that is because of the splinting effect. The
Yes.
bladder acts as a siphon. So it is at an upper position, then the urethra opens due to gravity. Women do pass urine. In this particular case, there is a weakening of the pelvic diaphragm. Can Chitra mute everyone, please? So whenever there is a descent, weakening of the pelvic floor, like age, multiparity, or delivery by untrained eyes, this uretrovesical angle is lost. Whenever this angle is lost, or the angle is straightened due to hypermobility and funneling, this will cause a leakage of urine, mainly whenever there is an increased intra-abdominal pressure. Yes, madam. So, next slide. Can anyone elaborate on how will we evaluate? Because we get these kind of patients in the OPD. So what history will we take? Uma ma'am, what is the history we would like to take in these kind of patients?
How long the patient
Yes,
is
old.
having how long the patient is having symptoms, and any history of other urinary symptoms, madam, symptoms suggestive of UTI, any history causing increased intra-abdominal pressure such as chronic cough or any abdominal distension, any constipation, that should be asked, madam. Past history of any medical history of diabetes, hypertension, any other surgical history should be asked.
So history is very important, especially in menopausal women as well as childbirth trauma, multiparity. And also there are associated urinary symptoms or bowel symptoms. As madam told, chronic cough and constipation are going to be aggravating factor apart from the predisposing factor of childbirth trauma and multiparity. And also looking into the medical conditions like diabetes, hypertension, which will help us to decide on the management. What examination will help, Dr. Divya?
A proper examination, like proper quantification of the like prolapse we have to do. We have to do general examination and also the gynecological examination, which includes the proper POPQ with the evaluation of all values. And apart from that examination, I feel a patient will be having a chronic infection, so which have to be ruled out by history and also with the investigations of mainly simple urine routine and then urine culture sensitivity. Most of the time, patient with incontinence with prolapse will be having a urinary infection, which has to be addressed today. And any other like obesity, general exams like obesity, her BMI, and any mass in the abdomen, which may be there associated, which will not be like if we ignore those symptoms, they can be missed even after surgery. Patient will continue to have symptoms. So all those things has to be addressed in the examination.
Yeah. So it is important we have to reduce the mass as said. After reducing the mass with a comfortably full bladder, we need to do the examination the dorsal position to check for stress leak. And if there is no leak in the dorsal position, we can do either with the standing position also. If the patient does not have symptoms, it is important to do evaluation prior to planning a surgery. And as we all know, we are not doing a Q-tip test, which helps to assess the urethral hypermobility, which is not done. Basically, it is done in the United States. And the post-void residue is a very important test which we need to do either by doing the pre-void and the post-void. Post-void testing is usually 1/3 the pre-void. If she has got a 300 or 350 or a 400, then the pre-void will be somewhere around 100 to 150. It is not a generalized statement saying post-void is less than 150 or 200. And very important to evaluate using a bladder diary. And Dr. Sumangli, can you just elaborate on bladder diary?
It's very important to know that, I mean, as Madam previous speaker said, whether the immediate sensation of urination she is voiding, or because she is complaining of stress incontinence. After our examination, it's important to explain to her the maintaining the bladder diary, and then before doing the urodynamic study.
Yeah. So it is important. We have to do a bladder diary, and that too, the bladder diary should be done at least 2 to 3 days, including the working days and leisure days, asking her to take the intake, output, as well as the leak episodes. Yes, thank you, Dr. Sumangali. And next, moving on. Can we go to the next slide? Chitrakala. So what are the treatment options which are available to this patient, Chandra ma'am?
Yes, there are two, whether medical treatment as well as surgical, but for this patient, it is 3rd-degree prolapse. So we have to better to go for surgical because she has got both urovaginal cystocele also. So we have to correct it surgically. Before that, we have to correct her. If she is obese, weight reduction and lifestyle changes, everything will help. But still, final treatment will be surgical.
Yes, madam. So as we have already dealt with surgery, can we discuss some more about conservative measures if she says, I want to get the surgery done later?
Okay, then we can, in such cases, we'll ask them to give all these pelvic floor training, Kegels, everything we'll be telling, and we'll be using pessaries. For initially, we'll use the pessaries that are depending upon her prolapse. We can use either the ring pessary or hug pessary. We were using it those days like that only, and we can try it whether it gets the symptoms gets better with all these pessaries. If she is okay with this pessary, then we can give her, in addition to this lifestyle management, reduction of weight and Kegels exercises, we can try a pessary also.
So as madam said, it is just only to buy time. We can try our traditional ring pessary by the trial and error method. We can either use the small, medium or large. It's only a trial and error method. If we insert a small pessary, it may fall off. If we are using a larger size pessary, it may cause obstruction to the flow of urine, and also she may have difficulty in passing stools. So it is important to fit in a correct pessary. And sometimes these may relieve the urinary incontinence as well. And Dr. Radha ma'am, what is the role of vaginal estrogen before surgery?
I want to add one thing. The pessary should enter into the cervix. While introducing this pessary, we have to introduce through, circumscribe, should be circumambulant of the cervix, so that it will get stuck. Sometimes it will not be possible because atrophic uterus means the cervix will not that much. It will have been atrophied. In such case, it may not be possible. But when cervix is felt and cervix is feel, we are able to feel, then we can introduce the pessary in the cervico-uterine cervical margin.
Yes.
Vaginal estrogen is okay.
Yes. Yes, ma'am.
Vaginal
Yes,
estrogen is very useful in many cases I've seen, because the mucosa improves quite a bit, vascularity improves, and these cases in which postmenopausal atrophy of the urethral mucosa also it helps. There are many patients who are quite relieved of their stress incontinence. They are not able to explain it's only stress. Even earth incontinence gets relieved. Vaginal estrogen is very useful in many of the cases.
Yes, thank you, madam.
And
So, as we are, yeah, yes, madam. So, as madam has rightly told, there is a decrease in the estrogen receptors as well as estrogen per se in the trigone part of it. So, sometimes the estrogen which is locally applied also helps in treating the prolapse
stress
per
incontinence.
se prior to surgery, as well as in some symptoms of incontinence. And
Yes.
as Chandra madam told, we need to identify before inserting the pessary. We should know the distance between the pubic symphysis because we are going to place behind the pubic symphysis and at the level of the sacral promontory. Yes. So what about lifestyle measures, Dr. Uma Brinda ma'am? Dr. Divya? Is Dr. Uma Brinda ma'am is there?
Yeah. Definitely, weight loss helps actually. The obesity is the main reason which increases intra-abdominal pressure. We have to encourage them for weight loss, and you have to avoid constipation because which also increases the intra-abdominal pressure. So, chronic constipation or if at all a chronic cough, it has to be treated, and we have to emphasize on the weight loss. We have to tell them even if you are buying time now, we have to go for surgery. And after surgery, to prevent wall prolapse, it is always better to follow the lifestyle measures, so which may help her so that she'll not get those symptoms again. And mainly you have to emphasize that. Along with that, with the Kegels exercise, she has to continue the Kegels exercise.
Yes. So as madam has rightly told, we need to do lifestyle measures before planning a surgery, weight loss management, avoiding constipation, chronic cough, and also if she's a smoker, to avoid smoking. And trying a Kegels exercise may help in level 1, stage 1 to 2, rather than 3 and 4. And in this case, particular case, all the conservative measures may not work for her. We need to plan for surgery. So what will be the surgery, Dr. Divya? And so can you explain a bit on Kegels exercise, Dr. Divya, before we move on with the surgery? Next slide. Just to explain Kegels exercise.
Kegels exercise. Hello?
Just
Huh?
can you explain on Kegels exercise before we move on to
Yeah, it
surgery?
is voluntary contraction of the voluntary contraction so that they hold the anal muscles, so perineal muscles, so that they are like we have to tell them they have to control their urination or something, so that they do voluntarily at least 8 times. It is recommended 3 times per day. So it can be done by doing any like they can do those exercises at any time part of the day during any work, but preferably in the lying position with lifting the pelvis up, and if they do, it is effective.
Yeah. So it is important. We need to remember, as Divya said, it is 8 contractions, 3 times a day. Try it for at least 3 months or 12 weeks. And the holding should be at least for 15 to 20 seconds. Next slide. Can Dr. Sumangli explain on the surgical management? As already told, vaginal hysterectomy with pelvic floor repair.
Yeah,
Before that, the uterosacral ligament tightening.
Yeah,
So can
to
you
prevent.
explain more on that? Elaborate more on that?
Yes, ma'am. So since this is a stage 3 prolapse, she's a candidate who may have a wall prolapse. So to prevent that, definitely we have to do a uterosacral ligament suspension, or we can fix it with to the sacrospinous also, and then as well as the Meckel's high Meckel's cultoplasty.
Yeah.
And for the incontinence, it's because she's having an overt incontinence. We may need to do the sling procedures also along with the vaginal hysterectomy part.
Yes. So it is important that we combine the procedure of vaginal hysterectomy, the ward Mayos, along with that a McCall's cultoplasty. In all the surgeries, we need to fix the uterosacral. The take-home message will be fixing the uterosacral ligament to the vault. Either we do a vaginal hysterectomy or abdominal hysterectomy, laparoscopic or a robotic hysterectomy, and also do the repair, site-specific repair using the native tissue, like for cystocele, doing anterior colporrhaphy, posterior colpoperiorrhaphy, and the incontinence surgery. In this case, as we are doing a vaginal hysterectomy, it would be likely a mid-urethral sling, either a TVT or TOT.
Okay.
Can Radha ma'am explain on taking the procedure TVT or TOT, any difference? Anyone?
TOT will be preferable, ma'am.
Yes.
But for, yeah, I mean, if we are not doing a vaginal hysterectomy, TOT tape will be easier procedure comparatively. But maybe in this patient, we can do a transvaginal tape as well, because anyhow we are doing a hysterectomy.
Yeah. So simultaneous, the mid-urethral sling reduces the future risk of de novo stress urinary incontinence after prolapse repair. So it is important that we reduce the mass, do a cough stress test, and check, do a surgical combination of vaginal hysterectomy with the SUI repair simultaneously. Next slide. Divya, can you tell about the grading of SUI? What are the grades we know? Prior to surgery, how are we going to grade the SUI? Divya, Sumangali?
Yeah, ma'am. So SUI can be like from 0 to 3. So 3 being the incontinence, even with mild stress or even with minimal activity. Whereas grade 0 is there is no leakage. So then grade 1 is only on severe stress they have the incontinence, and grade 2 is moderate stress, like just like walking or jogging or doing some exercise, they have the incontinence. So we have to actually correct the grade 2 or grade 3 by surgical methods.
Yes, thank you. Next slide. So what are the types of SUI? As we already dealt with the SUI, like whether it is a urethral hypermobility or intrinsic sphincter deficiency. Based on the types of SUI, next slide, Chitra, we need to decide on whether we are going to do TVT or a TOT or a pubovaginal sling, which was explained earlier by Dr. Harini. So if it is a urethral hypermobility, it is better we go for a TVT or a TOT. But if it is an intrinsic sphincter deficiency, it is important to do a pubovaginal sling using the rectus fascia sling or a tensa fascia lata. Next slide. So can Chandra ma'am explain on occult stress urinary incontinence? Chitra, can you move one more slide?
There are 3 types.
Chitra, can you move one more slide? Yeah, thank you. Yes, ma'am.
Occult means there have been latent or masked stress incontinence, and when prolapse gets worsened, this incontinence tend to improve because it becomes, once prolapse is reduced, then it kinked, that urethra gets kinked, and so that there will not be any stress and it gets obstructed. So manual reduction, as I earlier told you, manual reduction of the prolapse or placement of the pessaries will trigger the return of the same symptom, because with the cystocele it gets cured as it falls cure, but when it gets reduced, then again she'll have this stress urinary incontinence. So this we call it as occult urinary incontinence.
So it is important we have to find out the occult SUI before planning for a surgery. Thank you, madam. Now, what are the surgical corrections? Can Divya explain on TVT? Next slide. Chitra, next slide. Next slide. Chitra. Divya, can you explain on transvaginal tape? Divya, are you there? Sumangali?
Yes, ma'am.
Next slide. Chitra. Chitrakala, can you move the next slide? Yeah, can you explain on transvaginal tape?
Yeah, this, as you said, it is to correct the hypermobility of the urethra. So we use a polypropylene mesh, and it's a minimally invasive using a small typical needle is used for this, and we introduce the mesh, and then we elevate or we correct the urethrovesical angle. That's what is the base for this tension-free vaginal tapes.
Yeah. So it is important that we need to know tension-free vaginal tape. Usually the retropubic tapes, they go behind the pubic bone, and there is a higher incidence of entry into the bladder. If there is an entry, we need to visualize cystoscopically and remove the needle and reapply. It's mainly for correction of urethral hypermobility, a cause of SUI. Can Uma Brinda madam explain on TOT? Next slide, Chitra. Chitrakala. Chandra madam. I think they are disconnected. Trans operator tape.
Previously we were using that tension-free TVT. Then later on we started to use this TOT. That's a trans operator tape. But it involves the we could be having that needle which enters into the labia majora, lateral aspect of this labia majora. We take the bite on one side, and then the other side also the same. The other trocar using, and will be taking out through the other side labia. Then finally we adjust it accordingly, and then we cut off that trocar from that.
Yes. So it is important. We need. Yes, ma'am.
Yes. There are two approaches, one from inside to outside or outside to inside.
Yeah. So
depends
both the
upon
techniques are. Yes. Yes,
it
madam.
depends upon the performer. They are well trained in which way they are trained, then you can use it similarly. Both are equally. It's easy to perform only. Once you get trained, then it's easier only.
Yes. So it is important. We need to know it's a blind entry. Either you go from inside to out or outside to in, so that you're causing the support of the urethra. Whenever the patient coughs, this acts as a hammock to prevent the urine from leaking from the urethra. Next slide. Is it safe to perform midurethral sling with prolapse repair? Radha ma'am. Can we combine prolapse repair with midurethral sling? Radha madam? Dr. Uma? Dr. Divya? Dr. Sumangali?
Yes, ma'am, we can do it. I mean, if we after reducing the prolapse, she still has the incontinence, then it's better to combine because it avoids another anesthesia and another surgery. It's always better to do it along with it, and it's safe also.
Yeah. Chandra ma'am, should UDS be done in this case, this particular case? Urodynamic study.
Not mandatory, of course. Nice guideline says it's so in straightforward cases.
So as madam said, in straightforward cases, no need a urodynamic study. Only when there is a mixed incontinence and we have difficulty in making the diagnosis of genuine stress incontinence. Sumangali, can prolapse surgery alone cure SUI?
Most of the times, ma'am, but sometimes the SUI may persist after the prolapse surgery. That is why we need to do this surgery. But most of the cases, the mild cases of stress urinary incontinence get corrected with the prolapse surgery.
Yeah, thank you. So
usually we do anterior colporrhaphy along with this vaginal hysterectomy. That itself will cure the stress. Because always we'll be doing along with that anterior. In such cases, while we are doing that, it gets many times it gets cured automatically after the surgery.
Yeah,
but if
in
it's
over
due to
cases
intrinsic,
where there is if it is the cause is intrinsic sphincter deficiency, it really doesn't help. So we may need to correct the stress urinary incontinence in that particular case. Thank you. So we have given real take-home messages from this case, wherein there is a third-degree prolapse with SUI. We need to plan the surgery. Before that, giving them lifestyle modification, conservative measures, giving Kegels, and then planning the surgery till we have time, and then putting on a estrogen or a pessary may help in correcting the decubitus ulcer. Then we have time to plan the surgery as well as SUI repair. Moving on to the next case. Next slide. So this is a 56 years old, para 3, live 3, all are normal vaginal deliveries. She is a postmenopausal woman who's a teacher by occupation who comes to the gynecology OPD with complaints of increased frequency of urination for the past 6 months. She gives history of going to the toilet every 30 minutes and changes 5 to 6 pads per day. She has urgency to void and she wets herself before reaching the toilet. Also, she gives history of nocturia and mass descending per vaginum. She drinks 8 cups of coffee per day. On examination, she has stage 2 uterovaginal prolapse. Here, the cough stress test is negative. Madam, what is the diagnosis? Radha, madam. Next slide.
Urge incontinence, ma'am.
Yeah. So it is a prolapse, stage 2 uterovaginal prolapse as well as urge urinary incontinence. That could be a detrus or overactivity. Can you move the next slide? Chandra ma'am, how will we make a diagnosis of urge incontinence as Radha ma'am told in this particular case?
Yes, since she has frequency of urination, first we have to rule out urinary tract infection. Then we'll
Yes. So we need to rule out
and then
urinary
finally
tract
we have to
infection.
undergo urodynamic studies. All these
Yeah.
three investigations are must.
Yeah.
And
So
one
it
more
is
thing, she
important
has
to take a
this.
Yeah.
Yeah, she intakes coffee or caffeine again, which may act as a diuretic. So I think that also has to be stressed to the patient to reduce the coffee intake in this case.
The
So
bladder
that is
diary helps us to know when she's having leak and how much liquid she take, and all those things which has to be addressed in the bladder diary.
Yeah. So it is important we keep a bladder diary at least for 3 days, including working and leisure days, wherein we can write down everything, whether she's taking coffee or she's a smoker, drinks more at bedtime. So the voiding frequency is normally, in a normal woman, it is less than 8 times a day and once at night. In this particular woman, if there is an increased frequency and urgency to pass urine in the loo, and also nocturia, this we call it as fun symptoms. Along with that, if there is going to be a urgency leak, we call it as urge urinary incontinence. We call it as wet OAB or a dry OAB. Wet OAB when she leaks before she goes to the loo, or a dry OAB if she doesn't leak, just has the symptoms of frequency, urgency, and nocturia. And in most of the cases, we may not require a urodynamics. But if we have a difficulty in making a diagnosis, we may have to do a urodynamics. Next, how
And
are
you
we
have to
going
rule
to
out the
manage this
diabetic
woman?
status also.
Yeah, it is important to rule out the medical conditions like diabetics in this woman, because that could also mimic symptoms of frequency, urgency. Yes. Thank you, ma'am. And how are we going to manage this particular teacher? Radha, ma'am.
Madam, lifestyle modification, as we spoke earlier, and bladder training is very important. We should ask her to void by 7 in the evening.
So, yes. So, bladder training is very, very important apart from lifestyle modification in this woman. She's a teacher, taking more amount of coffee. So, reducing coffee intake and
If
also
still we are
bladder
not,
training. Yeah. Yes, ma'am.
bladder training is we should ask her to hold as long as possible, and once she is having that urge, only when she is unable to do it, she should go and void. And we have to ask her to go in between, take a frequent break and void frequently.
Yeah. So, it is important restricting the fluid intake. If she's taking more intake, to make it as 1.5 to 2 liters per day. She has to have 2 liters bottle, like 1 liter in the daytime and one before bedtime. She has to avoid drinking fluids, and also especially the fizzy drink she has to avoid, and increasing the time between voids. If she voids every 1 hour, we have to ask her to increase the time, like 1 hour 10 minutes, 1 hour 20 minutes, like that. And also putting them in, getting involved with support groups, especially helps them to have a good bladder training. And if she's on diuretics, asking her to stop diuretics. And if she's a diabetic, we have to treat the diabetes to have a good control. Yes. Next. Now, what are the drugs which are available for overactive bladder? Divya, are you there? Divya? Dr. Uma
Yes, ma'am, answer.
Yeah, Divya, yeah, you
Anticholinergics
can
like
take. Yes.
oxybutynin, saltadine,
Yeah.
darifenazine, and chlorifenazine. But the mirabegron works better usually, beta 3 receptor agonist. But we have to see like which we have to start with the lower dose, and before that we have to try all the lifestyle modifications. If it doesn't work, we have to go for the medications. And apart from that, I want to add one more thing. If she is on any medications, we have to look for the medical history because many of the antihypertensives will be combined with diuretics. So she may be telling us that she's not taking a diuretic but an antihypertensive. So we have to review her medication in case she's having increased frequency of urination or not. And we have to explain her all the side effects of the drug. And usually they come with side effects, but we have to adjust accordingly.
Yeah. So also we need to explain the side effects, adverse effects like dry mouth, constipation, and we have to tell her it means to say that the drug is having effect, and at least the drug effect starts 3 to 4 weeks. Either we can have a telephonic review or a face review to find out whether the drug is working. And if she doesn't have a good symptom control or she's not able to comply with the side effects, we can switch over from one medicine like oxybutynin to tolterodine or darifenazine or solifenazine, or we can give a combination, especially the the mirabegron with solifenazine. A combination has fewer side effects and best accepted combination of drugs for the treatment of urge incontinence. Yes, Divya,
Yes.
thank you. Now, how are we going to manage prolapse in this particular case as we are managing the overactive bladder? Dr. Sumangli?
Yeah, it's a second degree prolapse. So apart from the Kegel's exercise, we can start up, give a pessary. Nowadays, the silicone soft pessaries are available, which causes less erosion and less discharge. And of course, a vaginal cream, and also try with these medications. So as to, because it's a mild to moderate prolapse, she may improve without surgery.
Yeah. So thank you, Dr. Sumangli. It is important to note here that the guidelines, NICE guideline states level 1, stage 1 to 2. The pessary alone itself helps by supporting the prolapse and relieves the bladder irritability. And estrogen, because postmenopausal, the atrophic changes really helps. And in mild to moderate prolapse with urge urinary incontinence, usually they improve without surgery. Thank you, Dr.
Yes.
Sumangli. Next slide. So, Radha ma'am, when is surgery indicated in this particular case? Usually we go for conservative management. When do we do a surgery?
When she's not relieved of her symptoms, even with the combination of drugs, and she's suffering because of this, we can go in for surgery for such patients.
Yeah. So as madam said, when there is a severity of prolapse causing a bladder outlet obstruction or refractory to conservative management, like whatever tablets we are giving, she is not responding, or we are giving a pessary and it is not getting relieved, or there is a recurrent urinary tract infection. Chandra ma'am, does pelvic organ prolapse cause per se urge urinary incontinence?
Yes. By altering the bladder outlet dynamics, this prolapse, as we already told, that the angle gets obtuse, then it and irritation and everything will produce bladder wall irritation that will produce a frequency of urine.
Okay. Thank you, Chandra ma'am. And
It gives you a feeling of incomplete emptying. So she wants to go to the toilet and the restroom and void. That irritation will be there.
yes. So prolapse usually causes a urge urinary incontinence through as Madam said,
Incomplete.
altered outlet dynamics, irritation of bladder wall, and incomplete emptying. And Dr. Uma Branda ma'am, will prolapse repair cure a urinary incontinence in this particular case? I think Dr. Uma is not there. Dr. Divya?
No, ma'am, like stress urinary incontinence, it gets better with prolapse surgery, but for urge incontinence, it has to be tried and
Medically.
evaluated before going for a surgery.
Yeah, so SUI, we may go for a surgery, but here it is important to treat medically and then only plan for a surgery. Dr. Sumangli, should we do a sling for urge urinary incontinence in any case?
No, ma'am, not at all. So
Yeah.
it is
So
only
there is
for correcting the stress we do the sling surgeries.
no role for sling in urge
Maybe
urinary
if it's a
incontinence.
combination, then we can go for a combination of stress and urge. Then we correct it
Yeah.
medically and then do the sling.
Yeah. So it is important to identify which is a predominant symptom. If it is a mixed incontinence, the major contributory factor is stress, then we have to go for surgery. The major contributory factor is a urinary incontinence due to urge, then we correct the urge simultaneously. Dr. Radha ma'am, can pessary help urge urinary incontinence?
Yes, madam. As we spoke, prolapse can cause urge incontinence because of irritability of the bladder wall and all. Once the prolapse is relieved, it reduces the irritation and so the urge symptoms goes. Basically, she will feel better because something is supporting below and that feeling itself, I think, will relieve her urge incontinence. Because it's always that incomplete emptying feel, which is the cause for her urge incontinence with prolapse. Pessary will relieve all this.
Yes. Thank you, Radha ma'am. So the take-home message in this particular case will be, next slide, in prolapse with urge incontinence, treat the incontinence conservatively first. Surgery, as Madam said, Radha ma'am, it's reserved for symptomatic prolapse, failed medical therapy, and refractory voiding dysfunction. So I request each panelist to give a take-home message from this particular discussion. Chandra ma'am?
Yes. Yeah. Whenever a patient comes with this type of complaints, mass descending per vagina, and first we should concentrate on the give importance to the first symptom of her, which is the prior one. So depending upon that, we have to treat accordingly, and depending upon the diagnosis, whether prolapse is more or the incontinence is more, depending upon that, we have to treat.
Yes. So it is important to take a history, treat the symptom, which is giving bothersome quality of life problem. Radha ma'am, take
Yes,
home
ma'am.
message from your.
I would give so much importance to history as you told and identify incontinence. It's incontinence which is much more disabling to a lady than the prolapse as such. And lower grades of prolapse, I think giving good bladder training, doing Kegel exercise with the aid of those Kegel dumbbells which is available in the market, not just doing a Kegel, they can use those dumbbells also and use the dumbbell as a prop for doing the exercises. And treating urge incontinence, stress incontinence, giving her estrogen cream, just as soon as we diagnose prolapse, take some time, do all this and then go in for surgery. Surgery will not relieve most of our symptoms. It will just remove the mass that is descending, but it is not only the mass which is causing a problem. It is her incontinence, which is very demoralizing for this lady.
Yeah. Thank you so
I
much,
want to
madam.
add something, Dr. Meena. Most
madam.
of these women, they don't come out with complaints. They feel guilt, and they don't reveal it to their own wards also. So we should create some awareness among these perimenopausal and postmenopausal women. They come in the last stage only. They don't reveal, and they are somewhat depressed because of their urinary smell complaints. No, so they don't reveal it to the. So we have to create awareness. We as gynecologists, we should create awareness. That's my message.
Yes. Well said, madam. It is important we bring out the history rather than they come out and tell at the later life. Thank you so much,
Yes,
madam.
ma'am.
Dr. Uma
Woman
Branda,
actually.
madam, are you there? Uma
Yes,
Branda,
yes.
ma'am.
Uma, okay.
Uma madam is not there. Dr. Divya, can you just take
Yeah,
tell her
as
take
ma'am
home
said,
message?
actually, women suffer in silence. Usually, most of the cases, only if we ask history, they tell us. Otherwise, they don't tell us the leak if a patient is coming for some other complaints. My point is a simple 3-day bladder diary, like what input, output will give us a lot of information. And we have to educate the patient to do that if they are coming with a leak, so that it helps us a lot.
Yeah, excellent. So simple bladder diary, even without doing any conservative management, we'll be able to guide them on their bladder hygiene. That is very, very important. Thank you, Divya, for the very important take-home message. Dr. Sumangali?
Yes, ma'am.
Wind up the
So
session,
day in and day out we see prolapse cases, but it's always important to find out if they have the incontinence and correct it simultaneously. And also, most important is do not overcorrect this thing also. It may be a mild incontinence, so grade the incontinence and correct it accordingly.
Yeah. Thank you, Dr. Sumangali. So it is important we grade as mild, moderate, severe. Treat only the severe conditions rather than treating the mild and moderate. Thank you so much. Next slide. So thank you, TNFOG team, for having given us this opportunity to moderate, and the excellent panelist, Dr. Chandra ma'am, Dr. Radha Madhavi madam, Dr. Uma Brinda ma'am, Dr. Divya, Dr. Sumangali, for having given excellent take-home points. Thank you, Anjarakshi ma'am, Sampath ma'am, for staying with us. Thank you, Chitrakala, for the platform. Thank you.
Thank you, madam, for this opportunity.
Thank you, madam, for this opportunity. Yeah.
Thank you, TNFOG, for this opportunity.
Thank you very much, the moderator and the panelists. The panel was very, very very practical. Like we had all of them talking most of the points from their and experience. It was great. So with this panel, we come to the end of today's program. On behalf of the TNFOG, I'd like to propose a formal vote of thanks. Be with us and this program. Alpesh Gandhi sir, though he was not able to be with us. And the Yuva speakers are judges who've been marathon judges with us. The wonderful talk about the urogynecology with all practical points by Dr. Meera Raghavan and the wonderful panel. And thank you, Sheel Connect, and thank you, Shri Priya, for all the event management and all the other things. And thank you, everyone, for all the delegates for joining in. Thank you, one and all.
Thank you, Gayatri.
Thank you, ma'am.
Thank you, Radha.
Madam.
Chandra madam, Anjarakshi madam, சொல்லுங்க மேடம்.
என்ன போனை ஆஃப் பண்ணி வச்சுட்டேனே.
இல்ல மேடம், அது சார்ஜ் சுத்தமா இல்ல, அதனால ஏரோப்ளேன் மோட் போட்டு சார்ஜ் வச்சிருந்தேன்.
அப்படியா? அது எதுக்கு ஏரோப்ளேன் மோட் போட்டு வைக்கணும்?
ஃபாஸ்டா ஏறுமா அப்படின்னு யாரோ சொன்னாங்க.